All right. Well, thank you all for, again, taking time out of your very busy schedules for this extravaganza of a Nurse Talk. Today, we are very, very delighted and privileged to be hearing from the very hardworking and very beautiful Dulcie. Now, Dulcie, as I'm sure you all know, because we have a huge Papua New Guinea contingent online, is from the Milne Bay province in Papua New Guinea. And she is currently working with a very supportive and wonderful team at Alotau Hospital, specifically in ICU. She has been very passionate about nursing since about the age of 6. And has been working very hard throughout her nursing career, and actually graduated with a diploma in general nursing many, many years ago in 2012. She's continued her studies since, and in 2021 graduated from the University of Papua New Guinea with a Bachelor in Clinical Nursing, specializing in critical care nursing. So I think a qualification that is very close to a lot of our hearts. She has had a varied career, has managed clinics and wards, and also recognizes that she hasn't finished studying yet, and would like to continue studying and hopefully attain a education qualification soon. So wonderful to have you join us, Dulcie, and thank you so much. I will hand over to you.
Thanks, Beth. Thanks everyone for joining us this morning. I mean, it's already midday. And along with me, I have my team, which I acknowledge, and I want to thank you all right around TNG for the support that you have given for this presentation, to be made possible today, including Beth. Thank you so much. Okay, so we are going to share basically a success story. We call it a success story because we come from a very limited resource place where we get to see a lot of sick patients. And you will see in the next slide that our province is made up of mainly islands. Milne Bay province is a maritime province, and we've got a lot of scattered islands. Alotau district covers the mainland, as you can see, the large land mass in black is Alotau district. The other districts are mostly made up of islands. And so this makes it difficult when it comes to managing sick people. This is the only provincial hospital that takes care of the entire, specialist hospital that takes care of the entire province. And we get to face a lot of issues with delays in bringing critically ill patients for specialist care. Our population as of 2021 estimation stands at that. Almost 200,000 comes from Alotau district. We understand that with the urban drift and migration into town for job opportunities and that sort of things, the population for Alotau town has increased at a fast rate in the last 5 years. And we continue to see that in the health care delivery services. Our systems are under a lot of pressure to meet the demands of the growing population. Okay, before us, you can see pictures. Because we are a maritime province and we are connected by sea, most of our transport would be by sea, as you can see, and we have patients coming in on the boats and small outboard, dinghies, motorboats. On the left-hand side, This was a recent referral from one of the islands that we brought into Alotau, and you can see how we tied our IV drip really nicely using fishing lines because it was very rough and the IV fluid kept swaying. And our management has partnered with other NGOs to ensure that we continue to provide services. One of those is Dr. Barry with his seaplane. It's called a Hand of Rescue, where there are a couple of times he had to fly out into the islands and bring in women in labor and attend to them as well on the islands. During the pandemic, he had to fly into Australia to bring in some supplies, and we acknowledge his service to Milne Province. Above there, that's Paul then facing the chopper. That's Manalos Aviation. When the seas are very rough and winds are strong, our management brings in patients on this chopper. And so Manalos has been also providing services for us. We had YWAM visiting to also provide healthcare services, but after the pandemic, the boat has stopped coming to our shores. This is the famous icon of Alotau town. And Alotau is the capital of Milne Province. It's located on the eastern tip of PNG's main island. And there are 160 plus main islands surrounding this. It's the main port. And Alotau is also known for the site of where the World War II ended. And so that's the monument that you're seeing. Every year we get to commemorate the Battle of Milne Bay, and nurses are a big part of this commemoration. It was during this time that the nursing career became very famous. It was said that a woman by the name of Mayugaru hid an Australian soldier in her canoe and nursed her, took her for help, and he finally made it out back to Australia. And so this is where the war ended. The Japanese forces lost to the American and Australian armies. No offense to Japanese nurses around. We are friends. We love you. This was our history. We all went for a common good this day. But it's nice to have history together. Like I said, nurses are proactive and they're very vibrant when it comes to the celebration and commemoration of the Battle of Milne Bay, and it's our pride. Okay, I'm into our hospital setting. Our little setting sits on the hilltops of Alotau town, and it overlooks the famous Milne Bay. Milne Bay Provincial Health Authority, like I said in the beginning, is the only specialist hospital that serves the province, and mostly operates as the curative arm of the Provincial Health Authority, though we run public health services to support that directorate, because we have like the laboratory in the main hospital. We also support our other directorates who come in. The hospital has a total bed capacity of about 156. It may increase soon. There's approximately 20 clinical doctors. Twila will correct me if I'm wrong. About 7 health extension officers who also work in the hospital, and roughly 500 nurses. This is inclusive of nursing officers and community health workers who also support the nurses. It has the only intensive care. This is the only intensive care unit in the province. That's our side. Basically, our ICU, like I said, ICU has a 4-bed capacity, 5, but at the moment, the one in the isolation room is not being used. So we are operating with 4 beds. Okay, I would like to start with giving our strengths and the struggles that we go through. So when we present the, our case, our success story, it makes sense as to why we call this a success story. Okay, so one thing that we value in the critical care team here is that there is a good, harmonious working relationship right across all cadres, whether there are doctors, administrators, or clinical workers, nurses. We have a good working relationship and understanding. I'm sure every one of us have that. Yeah. We also have an established critical care system here. And when it comes to critical care, we are encouraged and urged that if I'm taking care of a very ill patient, and I have a resident, because we usually it's normal for the resident to attend to the patient, and then we call the registrar in, and then they get to the consultant. But in this system, when I need to consult the registrar or the consultant right away or immediately due to the severity of this patient's condition, then I can bypass that. And that's the thing we value, because all consultants' phones are 24/7 on, ready to hear from the small intensive care unit here. And when they see our numbers call in, they know that, okay, there is a very sick patient in there and we need to attend. Whether we are on call or not, we need to respond to find out what is going on the ground. Recently, under the leadership of Chief Dr. Famov, the head of critical care medicine here, he opened up a WhatsApp group, so we are able to see who is admitting into the intensive care unit, whether it's an ONG patient coming in, it's a medical patient, a pediatric patient, or a new admission coming through the emergency, a patient transferring in through the wards. All nurses and cadres of health workers are able to see that a patient is admitting and what's going on with the patient. In that WhatsApp group, we also have the Chief Executive Officer. We also have our directors, the laboratory technicians, blood bank, all areas covered within the hospital. So when there is a need, say, for example, if I need emergency blood and I post on the WhatsApp group, the blood bank has already got my message, they're preparing blood for this patient. Or if I call my registrar and say, oh, Dr. Okai Patwila, I have a patient who is this and this, and then she has a plan for this patient. She quickly goes on, updates the team, and so everyone is on the same page to work towards helping this patient. So it makes communication very, very easy for us. On the part of the ICU staff, we have an amazing staff on the ground who are very committed and very reliable on, so in, what do I say, after hours, and when doctors are around during 8 to 4 hours. And so communicate, sorry, the staff on the ground are kind of the eyes and the ears for our doctors, and they keep updating our medical officers on the conditions of our patients. We have planned workshops on critical care post-trauma that are run by our doctors here, and Twila is one of them listening here today. She is among the team of doctors who usually facilitate the critical care of the surgical patient and post-trauma care. And this way, our HOs, doctors and nurses also participate in. Our main struggles that we encounter during providing of care, and there are ongoing struggles that we face each day, are shortage of manpower. We still have a shortage here in the ICU. At the moment, we have 9 nursing officers who run the ICU. We are hoping that in the near future, we can be given 20 nursing officers. We only have 9, and 3 community health workers who work as nurse aid. We value these people very much. They are very senior CHWs, experienced nurses who make work easy for us nurses in the intensive care unit. I don't know if my other colleagues across PNG have done away with CHWs in the ICU. Alotau still has CHWs in the ICU because of the lack of manpower that we have. Maybe our knowledge is limited, skills and experience. We have more novice nurses entering into the ward, and we are happy to have them. We're trying our best to train them and allow them to learn so that they can be of help to us as well. We also have lack of resources in aiding patient care from time to time. Very important, essential resources like ABG, reagents, lab reagents. We are limited with 2 ventilators. Mostly like these are things that we used to provide quality care, but in our setting, essential drugs, life-saving drugs, Yeah. There are times when we let them and we have to do what we can do with whatever we have to try to aid our patients. The recent rise in law and order issues has also affected our workers. Our doctors live outside the hospital vicinity, and so in getting them to come on time may be a problem. At the same time, with more of casualties coming in from the police and boys around the place, criminals, there's a lot of admissions coming in, and it has put a strain on our systems as well and resources. And with all this, we end up having burnouts and fatigue because we are looking for resources to attend to the patient, at the same time having to attend to the patient, and then while waiting for help to arrive, we feel overwhelmed at times. But these are struggles that we face each day. We just tend to do what we can do, and whenever there's nothing much we can do, we understand that it's beyond our control. Let me take you into the ICU. So that's the doorway on the far left-hand top. That's the doorway into our small setting. Down below, you can see the inside of the ICU. So we don't have a fancy air-conditioned room. We just have louvers and fans. We have a 4-bed ICU. And at the time this photo was taken, there was 1 bed occupied. So the cabins are on the right-hand side is the kitchen where we prepare food for our patients. And just outside the door is the X-ray viewer. That's the isolation room where we keep our machines. And we had a portable X-ray before, it's no longer functioning. Before you can see the AOMed, and covered in the red cloths are the 2 draggers. So those are the 2 that are functioning at the moment. We have 2 mechanical ventilators. In the background, you can see there are 2 syringe pumps and infusion pumps. They are not in use currently. And so we are doing manual work. Our emergency trolley doesn't look so fancy, but it has saved a lot of lives. And yeah, you can see oxygen cylinders still at the bedside. For the last 5 years, there were no male staff in ICU, just females. And that is one of the exercises we do. We wheel cylinders up and down. Yeah, and of course, there's our treatment trolley, and the cupboard is on the far right hand top. So that's basically where we work and where the action takes place. So having presented our struggles and our triumphs to you, we had this case that came in, and we were very, very happy that she was able to make it, because at the time the patient came in, we had trouble with resources, like I said. We may have lacked certain consumables, and we were not able to do proper monitoring for this patient. But the fact that we were able to do basic close monitoring of this patient, got this patient with the help of our doctors, and we were glad, we were surprised that we were expecting this patient to take more than 3 days or even up to a week of ICU stay, but she got extubated after 24 hours and was transferred out. So that was a success for us. So she's a known hypertensive, but has been non-compliant to treatment. 2 days prior to admission, she had fevers and general body weakness, and so was taken to the A post close to her. She was treated with anti-malarials, which she took well at home, but then 5 hours prior to admitting to the emergency department, she fitted 4 times at home and became semi-conscious, and she was rushed to the emergency department. Whilst there, she fitted again, and so airway had to be secured under rapid sequence induction. Okay. On admission to the emergency department, those were her vital observations. Yeah. She had fever. She was very tachycardic. Work of breathing was labored. She had very high blood pressures. She desaturated, and blood sugars were elevated. And so the emergency team initially attended to her, she was reviewed by the medical team and later on admitted to the ward past midnight. Yeah. So the medical team admitted her at around 11 o'clock in the night. Okay, and we were notified that there was a patient coming into the ward. At that time, due to law and order issues, our doctors were at home and there were only nurses on the ground. I worked with a very senior CHW who is a very experienced nurse and a very resourceful person. She's worked all her life, almost 30 years in the intensive care unit. So she's very experienced and I rely on her. And so I told her I'll go up and check on the patient, just do a quick assessment to see how she is, and then I can consult our doctors to instruct us what to do this time while waiting for them. So I went up and saw the patient. At the time, she was hyperventilated. She's intubated, but breathing against the bed. There's not effective begging for her. We also ran out of sedations, like I said, in terms of resources, we were out of sedation. So she was more paralyzed than sedated, and she became very, very anxious, and that caused her blood pressures to really shoot high. So I came down and called my consultant, anesthetic consultant, SMO. I briefed her on the condition of the patient, and so she gave me the mechanical ventilator settings. By then we had already prepared the bed and our monitors to receive the patient. So once we dial in the parameters for the ventilator, we just waited for the patient to arrive. And the patient was admitted to the ICU at 2:45 a.m. She was agitated. On admission, she desaturated. She was her SpO2 was at 72%, though bad. And so we had to adequately sedate and relax prior to transfer onto the ICU bed. When we attached the monitors and the ventilator, then we were able to attend and do a proper assessment of her. Okay, so the baseline observations and admission to the ICU at 3 a.m. done. That is what we found out. And the thing that we were now thinking of, just by judging her SpO2 at 72%, we are now thinking she's already with hypoxemia, and PaO2 around it on the oxygen dissociation curve would be around less than 44, and that was very bad for her. So we had to adequately paralyze her to take control of respiration or mechanically ventilate. But also at the same time, because the paralysis that we were using would also cause the blood pressures to skyrocket. And that's what happened. So we just gave adequately what we could give to just control ventilation. Then when we assessed, of course, her blood pressures had come up, but airway-wise, her airway was secured. She was breathing spontaneously, so we had to give a bit of a tracherium to relax her. Saturation at that time was 72, like I said. So FiO2 was increased to 100%, and we continued to monitor the EtCO2 levels for her. So at the time, EtCO2 was about 48. Okay, because the diastoles were already high at 118, we just had to give a step dose of hydralazine to control the blood pressures, and continued routine assessments for her. Now, at 3 a.m. also, the thing we noted was that she was no longer passing out urine. So we had to call for help again. We were lucky that an MO was underground. So he just walked in to check on the patient when we informed him. So we had to start off fluid resuscitation for her again between 4 a.m. to 5 a.m. Blood sugar levels we were unable to check frequently. We had to delay because we had very few glucose strips available, and we had to kind of save it. so that we don't get to run out of them very quickly. But the blood pressures didn't drop very fast, so we were good with that. Yep, so that is basically her condition over the night. So basically, we tried our very best to control breathing, and for circulation wise, we had to try to keep blood pressures controlled. So for her, 200 and her blood pressures rose to as high as 256 systolic and diastolic, so 136 as well, and that was very, very high. Now we had to hold back on the atracurium under the advice of our consultant. We went mainly with sedations as per her orders and closely monitored blood pressures. We didn't want to drop the blood pressures too much, or else they would pressure us. So we didn't really give a lot of hydrolysis. She's a long-standing hypertensive. And so we try to maintain MAP around 107, about 96 to 107. So the blood pressures that we were taking would be around 140 or 90 to 100 diastolics. We had to maintain that, to keep in touch with our doctors. We were frequently updating our doctors, communicating with that, okay, this is what's happening, and okay, continue to do this while we wait for dawn. In the morning, as soon as it was time for ward rounds, doctors and medical officers on 14 had to come in and fully take over our patient. Okay, at the time of handover, that's the comparison between 3 a.m. and 7 a.m. After care that was provided at 3 a.m. as per the medical management plan and the nursing assessment, we try to correct certain correct the issues that were present. And then at 7 a.m., we were at least slightly relieved to say that the heart rates were slowly coming down after the fluid resuscitation. She was already breathing against the machine, so we had to change back to SIMV. Blood pressures from 200 on 100, 30 plus came down to 140 on 92 and remained controlled. That sugars were much the same. GCS, she was still under sedation, so we couldn't assess the level of consciousness as yet and her limb powers, but pupils from 5 had come down to 3 millimeters bilaterally and were reacting to light. We were happy that her saturations from 72 initially had rose up to 100, and again, because of lack of resources, we had to try to tap oxygen that early because we were also short of oxygen in the hospital. So as soon as saturation started hitting 99%, we started tapering slowly down from 100% right down to 60 when we left. So slowly tapered oxygen to see if she could tolerate that. And ATCO2 initially was 48. We were happy that it had come down to 40, and she was basically stable when we handed her over, though very sick, but at least she was improving when we handed her over to our morning colleagues. And that's when the ward round team took over, and the next 24 hours was under their management. And so, yes, basically they did all the investigations, the assessments and their care plan, and then from then on we continued as orders. For this case, she was a very sick patient. Like I said, we thought she would be in the ward for almost a week, but we were surprised and happy as well that she was able to leave the ICU. Like the 10-hour time usually for bigger hospitals. I practiced under POMGEN, and I was like, impressed that after 48 hours, patients are usually extubated or 24 hours. And here in a small setting, we still have to get to that stage. But for me to see this patient get extubated after 24 hours, I mean, that was, it was a good thing, and I was really happy about it. So what we did for this case here, basically, we were able to identify the red flags and call for help early, and then we recognize with the limited, we can say, knowledge that we had, we were able to apply the basic knowledge, and thanks to the trainings that we received, some of us were fortunate enough to attend the basic ventilation workshop under the USAID at Port Moresby. Just more recently, NZIX also conducted a training on critical care, which I was also privileged to attend. And so some of these things was cemented, during those training, and it gave me confidence to be able to perform those, especially in terms of mechanical ventilation and patient assessment. Yeah, and because of this, we were happy that we were able to communicate in our team time, and we were able to save this patient. She got transferred out of the ICU to medical ward where she recovered, and then finally got discharged home. So that's the happy story we have, and basically what we face each day, our triumphs and the struggles that we face, but this will always be part of our lives, and we are happy that we are able to make differences in people's lives. And I want to say thank you again for the wonderful support that you all are giving, and I'm glad to be part of you on this platform. Thank you. I think that's about what I prepared to present to you. Thanks, Beth. Over to you.
Dulcie, thank you so much. What an absolutely, again, inspirational story. And the challenges that you face, I think, are obviously well known to all of us online today. But I think being able to see the positives in all of those challenges is so important. And you certainly explained really, I think your last slide, instead of saying what we did, it should actually read what we did well, because all of those, so identifying that deterioration early probably was the absolute key to such a great outcome for your patient, along with the great communication, the support that your team provided as well, and applying all of the knowledge that you as a team have. So well done. I think very, very inspirational story. Has anyone online got any comments or questions for Dulcie about this particular story, or anything to add from your practice? Oh, was that someone wanting to ask a question? Oh, yes, Keela.
Dulcie, can you hear me? Can you hear me?
Yeah.
Okay. Thank you, Dulcie. Very inspirational. I know your challenges are real. And it's good to be real, and that's what makes us better. What would you recommend for us to help you with as far as nursing, ICU nursing is concerned? Is there anything that you can link with our ICU nurses in FOMGEN? One of your challenges you mentioned was your infusion pumps are sitting there. So what is it? Why they're sitting there? How we can help you in what we know? How can we share those knowledge together? Is there anything that we can share in common at the national level?
Sister Verobo, you asking me?
Yes.
Okay.
Alright.
Sorry, I couldn't really hear what you were saying. But could you repeat what Sister said? Speaker is a little bit low.
Yeah, Akila, do you want to try asking again to see if the connection is better now?
All right. I was asking, how can we help you at the national level with some of the challenges with the capacity that we are able to do? Like one of your challenges is your infusion pumps are sitting there, and if we can help you, how can we do that for you?
Thank you, Sister Verobo, for asking that question. I'm glad you asked it. One of the ways in which you can assist that now, we are moving into planning for the ward. Very soon, this space is going to be pulled down. We're going to have a restructuring. So we are planning for new equipment to come. But if you can get us the best company that you source your equipment from, so we can submit for this equipment to be supplied. Yeah, if we can get a quote for them and supply the quotations in our plan so that our management can be able to purchase these things for us. Another thing, we are just hoping and praying that our structure will pull through. In terms of manpower, yeah, we really need manpower on the ground, clinical manpower, nurses I'm talking about. Yeah, because at the moment, the ratio of patient care, nurse to patient care, we're supposed to have one specialist nurse to a patient. The truth down here is that if lucky, after hours, we have 2 nursing officers who take care of 4 intubated patients. So that's 1 nursing officer to 2 intubated patients. But if West comes to West and our roster is not able to cater for that, you have 1 nursing officer to 4 intubated patients. And it can become very overwhelming for us. And there are risks that we are able to make errors or overlook certain very significant red flags. So this is one thing we are just hoping that our management is going to push through and be able to give us manpower. Like I said, currently as we speak, we only have 9 senior nursing officers who are running the ICU. And if we are to provide quality care for patients, we need more than that. And maybe please you can talk to Sister Grace Mark at your level as to how best you can source manpower for us and help staff our intensive care unit. She's right here listening. Thank you, Sister Verobo.
Okay, thank
And
you.
I will keep in touch with you and Sister Babula and all senior nurses around the country. Now that thank you, you've asked that question. I am going to ask all sorts of questions from now and onwards when I need help. Thank you.
What's your, you have 4-bed capacity, so what's your occupancy rate like?
Occupancy rate like.
What's your current structure? What's your bed occupancy in your ICU? So what's your occupancy rate?
At the moment, sorry, our bed capacity in the ICU is 4. With the restructure due to spacing, I'm afraid we are still going to be at 4.
So what is your occupancy rate? How many
80%?
Occupancy rate?
80%?
Okay.
Yeah, but more recently, like I said, with the law and other issue, we've gone over 100%. We have in full beds in the intensive care unit, and we have to, because of motor vehicle accidents, gunshot wounds and all that, we have to make a decision. And some of these patients, I feel for them, but we have to decide to get them out of the ICU just to have another very critical one coming in. So yeah, we are also in a dilemma at the moment to have those decisions done. But like I said, our doctors, we have a very good team of doctors here, and they're able to help us make such decisions.
Thank you, Darcy. You did well. Well done.
Thank you.
Thank you, Sister Virobo. Any other comments or questions from anyone? I think that was a very good conversation to have. But any other comments from anyone else online? No. Dulcie, can I ask a quick question? Has the patient that you were talking about in your presentation, have you seen her since she got discharged from hospital?
No.
No.
She went home.
She went, yeah. I was just wondering if she remembered anything from her stay in intensive care.
Yeah, we would maybe on follow-up. Yeah, she will come through the doctor's clinic for her follow-up. Twila is listening.
Yeah.
Maybe she would be in a position to ask those questions on our behalf.
Yeah, it would be interesting to know if she did remember all of the great care and management she had, and how well you all did as a team to get her through.
Yeah.
All right. Oh, Praneel would like to ask a question. Welcome, Praneel.
Hi, Praneel.
Hi, Beth. Hi, Dulcie. Bula from Fiji.
Oh, Bula.
Just, it's a very motivational speech, a story that you've shared with us, with the limited resources, human resource and equipment, and you managed to effectively send this patient home. It's something to be motivated about. I'm just, it's not a question, it's more of a comment. I'm thinking about for staff's debrief. Dulcie, do you have any plan about debrief for staff's post resuscitation or post trauma call? Because you've mentioned about some law and order and some civil unrest in the location that you're in. Do you have any plans about staffs that can go through a debrief session after a traumatic incident?
Thank you, Praneel, for your question. Yes, we do have debriefs, but they are more of informal debriefs straight after resuscitation. Usually our medical officers are called in to confirm, and they're the ones who kind of give us that debrief to say that, look, there's not much we could have done about this case. Even if there was something we could do, maybe we lacked the resources and all that. So usually they are the ones who do that for us. Did I answer your question?
Yep, sounds good. Actually, it helps quite a lot psychologically as well. I'm thinking more towards our nursing colleagues after a traumatic incident, where we have a small debrief and basically talk about the incident and share experience. Because I mean, the shortage of manpower and the shortage of resources, we would not be able to do anything overnight. But little things like debrief and having a chat and talk through about providing some sort of emotional and psychological support really affects quite a lot, and it helps out our colleagues quite a lot. So thank you, Dulcie. Thank you.
Thank you so much, Praneel, for that. And yes, you are right. We need to look more into that because it can be overwhelming, very stressful on the part of nurses as well. We go home stressed, worried that I did not do much. And yeah, thanks for bringing that up. We will make it a practice from today on.
Thanks, Praneel. I think that, yeah, that was a really good comment you made there. I think that the value of certainly reflective practice and debriefing can be really beneficial. And can also help not only with maybe the psychological and emotional aspects of a traumatic event, but it can also be beneficial to look at system change as well, in the more sort of strategic long-term sense. So yeah, thank you. All right. Well, if no one else...
Can I ask a question?
Of course you can.
Okay. Dulcie, Sister Babona here. Beautiful presentation. Your story is almost similar to ours. Your staffing, the limited resource and things like that, the drugs, consumables. I'd just like to make a comment about the WhatsApp group. It's really interesting to know that you have a WhatsApp group that has your CEO on it. If that's correct, right?
Yes, yes.
Okay, just a question. Do you have your other directors also on that WhatsApp group? Because I like the idea of having that. We don't have something like that here in Engao. And it's nice to know that you have that. And do you feel that it's working, your communication with all the others using the WhatsApp?
Yeah. Yes, we do have our other directors on board, the WhatsApp group, and the hospital administrator as well. And so when we let resources and all that, they're able to see. However, it's not discussed on the WhatsApp group. They table it out at their level, and they try to assist us as best as they can. So our consultants from each section, like for us, the anesthetic SMO would take up our needs for the ward, and then try to liaise with the management at that level. It takes a while for these things to be procured, and the processes are very slow, so you just have to be patient to have these things arrive. Yeah, that's still the challenge we have. But
okay, thank you very much for sharing that.
Yeah.
That's something we're going to take with us, and I'll propose to our HOD if we can do something similar to that here in our hospital. So thank you very much, my dear.
Thank you, Sister Babona.
Awesome.
But while waiting, could I just, add on make a comment on the training part of it?
Of course.
Because we have only 9 senior nurses here in the ICU, we are trying our very best to train the novice nurses that are here. But we are not only providing, extending the training to the intensive care nurses alone, we are extending our invitation out to sister wards like the critical care units, like medical ward, the surgical ward, the emergency department, obstetrics and gynecology for nurses to join us. And so we started with the ONG department, and we have established right now as we speak, we have an ONG nurse who is on our roster, senior nurse who is on our roster. So the idea is that we want to help them to be able to practice the basic critical care principles. They are able to identify red flags, they are able to communicate effectively, and so they can intervene on time. So they've been having issues with their patients lately, and so because of that, their consultant requested that this arrangement be made. We're also looking at our sister wards like medical ward. We have Sister Alice here. She's with us. She's the in charge. We also working towards having that understanding and that arrangement where somebody from the outside ward can come into the intensive care unit to work with us to be able to practice what we practice in the ward, so that she can be able to go back and teach as well in the medical ward. So as the surgical ward, the pediatrics, we haven't done that yet with them, but because we know that in the long term, there's plans for pediatric intensive care units, so we are encouraging them to also join us so that they can be able to take care of their ventilated patients, in the future. So that's what we are doing. After the training in Port Moresby, we came to, I drew up a program, and Holden has tasked me with the in-service for the ward I started off well, but when we had the flooding of the ICU, I had to prioritize patient care, and so I kind of dropped a bit along the way. But when we have time in the patient care, we try as much as possible to be teaching one another, practice basics. Yeah, so that's what's happening. But one of the plans that we are looking forward to is, now that we are on this platform, is that we will ask one of you to be presenting in the topics to us via Zoom, so that we can be able to learn as well from you. Thank you.
Thank you, Dulcie. Wow, that is fantastic. I think the education program that you are providing to the wards, again, is going to be invaluable, because as we all know, critically unwell patients don't just go to an intensive care unit. They can be on the wards, they can be in the community, they can be anywhere. And some places maybe don't have an intensive care unit. So I think you're training your ward nurses to pick up deterioration and be able to treat them on the ward will go a long, long way to minimizing the risk of them ending up in intensive care. So I think that education program is so, so valuable. And I very much hope that you'll be able to keep it going, and would be very happy to assist in any way we can. So well done. That sounds awesome.
Thanks.
All right. Well, I think that has come to the end of our second NurseTOK session of 2023. Thank you so much, Dulcie, and thank you all for such a great turnout. I'm sure Dulcie is very, very happy with the support. And thanks for all the great questions and comments as well. It really does make it a lot more interactive, sharing knowledge, sharing experiences. Our next NurseTOK will be, so it's the third Thursday of every month. I can't quite work out what that will be in September, maybe the 21st of September, I think. We are looking for someone to present on anything of interest. It doesn't have to be clinical. We had Praneel talking about leadership last month, and obviously we've had Dulcie talking about their success story in Alotau this month. So please let me know if you would like to do the next presentation in September. All right, but until then, thank you all so much. Enjoy the rest of your day. I hope it's not too stressful. And we'll see you in a few weeks. Thank you.
Thank you.
Bye bye. Thanks, Dulcie.
Thank you.
Bye.
Bye.
Bye. Bye, Engau Yidi.
Oh.